Zavicefta, a combination of the third-generation cephalosporin ceftazidime and the novel non-beta-lactam beta-lactamase inhibitor avibactam that's effective against many difficult-to-treat infections due to aerobic gram-negative bacteria. This video will illustrate a summary of the Reprise trial, the first pathogen-directed clinical trial for Zavicefta, examining its efficacy against ceftazidime-resistant gram-negative bacteria. The prevalence of multi-drug-resistant gram-negative pathogens is increasing worldwide, including extended-spectrum beta-lactamase-producing and carbapenemase-producing Enterobacteriaceae and Pseudomonas aeruginosa. As the prevalence of ESBL-producing pathogens has increased, so has the use of carbapenems, frequently the last line of defense against MDR gram-negative bacteria, but now threatened by the growing prevalence of carbapenemase-producing pathogens. Therefore, Zavicefta, as an important new option for such cases, is assessed in this trial in terms of efficacy and safety. Reprise trial is a prospective, international, randomized, open-label Phase 3 study in which patients were randomized 1-to-1 to receive treatment with either 1 Zavicefta, 2,000 to 500 milligrams administered as a 2-hour intravenous infusion every 8 hours, or best available therapy. Patients with complicated urinary tract infections were diagnosed with either confirmed acute pyelonephritis or complicated lower UTI without pyelonephritis, with predefined signs and symptoms, while patients with complicated intra-abdominal infections were diagnosed by ceftazidime-resistant gram-negative pathogen, at least one of 8 specified diagnoses during surgical intervention, or by specified signs or symptoms of complicated intra-abdominal infections. The primary endpoint was assessment of clinical response at test of cure visit 7 to 10 days after last infusion of study therapy in the microbiologically modified intent-to-treat population. Clinical cure was defined as complete resolution or substantial improvement of signs and symptoms of the index infection, such that no further antibacterial therapy was necessary. For patients with complicated intra-abdominal infection, cure also required that no drainage or surgical intervention was needed after 96 hours from randomization, while the secondary endpoints included clinical response at other time points, clinical response at the test of cure visit, per patient favorable microbiological response, and per pathogen favorable microbiological response. The Reprise trial has shown many interesting results for Zavicefta. First, we have to mention that most patients in the best available therapy group received a carbapenem antibiotic, and the majority received this as monotherapy. Moreover, the baseline disease characteristics were similar between the two treatment groups. The majority of patients were infected with Enterobacteriaceae, and in 9 of the 10 complicated urinary tract infection patients with bacteremia, the isolates were E. coli or K. pneumoniae, the same pathogens as were isolated in their urine. Regarding efficacy, it was found that overall clinical cure rates at test of cure were similar between Zavicefta and the best available therapy in both complicated urinary tract infections and complicated intra-abdominal infections combined. If we have a closer detailed look, we will find that clinical cure rates at test of cure was similar between treatment groups in patients with complicated urinary tract infections, with 92% rates for Zavicefta versus 94% for best available therapy. And regarding complicated intra-abdominal infections, the proportion of patients with clinical cure at test of cure was 80% in the Zavicefta plus metronidazole group and 54.5% in the best available therapy group. What is more interesting is that per patient favorable microbiological response rates at test of cure in the complicated urinary tract infections population were higher with Zavicefta than with the best available therapy, and remained consistently higher at each subsequent visit. And regarding patients with complicated intra-abdominal infections, per patient microbiological outcomes score were presumed from clinical response. By the last follow-up visit, 31% of patients in the ceftazidime avibactam group and 39% in the best available therapy group had experienced AEs, with serious AEs in 5.5% and 6% respectively. Gastrointestinal disorders were the most frequently reported AEs, with both ceftazidime-avibactam and best available therapy. Generally, the safety and tolerability profile of Zavicefta is broadly similar to ceftazidime alone. In conclusion, treatment of serious ceftazidime-resistant gram-negative complicated urinary tract infections with Zavicefta results in similar clinical cure rates to treatment with best available therapy and numerically higher per patient favorable microbiological response rates. And in complicated intra-abdominal infections, clinical and microbiological response rates were also high for Zavicefta and in line with those observed with best available therapy.